Thank you very much, Nessa. So good afternoon, everyone, and welcome to this webinar on the concept of goal-oriented care. As I see that there are some new names in terms of the participants, I would like to also introduce myself. So I'm Andrea Pavlikova, and I work for Scottish Government, and I have a pleasure to coordinate this project, Široko Exchange, and together with my colleague Nessa Bari, we will moderate and run today's webinar. So we organized this webinar as part of our knowledge transfer program, which is basically now running from September 2020. And the objective is really to support regions and delivery organizations to build their capacity in integrated care through mutual learning, exchange of good experiences, lessons learned, good practices, and so on. So this webinar is organized as part of this program with our colleagues from Flanders who are part of the consortium. As I mentioned, the focus is the concept of goal-oriented care. So we will have a look at some theoretical background, what this concept means, but also I think very interestingly, we will have a look how this concept has been implemented and introduced in Flanders, and we will see some details of two ongoing projects. And then after these two key presentations, we will also explore the potential link between this concept of goal-oriented care and actually the concept of maturity model for integrated care, which we are introducing as part of our project, and explore together with all participants what are the commonalities, what are potential differences, and if there would be actually any scope for the adaptation and expansion of Široko Exchange maturity model to fit better to this concept of goal-oriented care. So there will be almost like three different sections. So we will kick off, as I said, with a bit of theoretical background, what this concept means, and we'll have the introductory presentations from Dagi, followed by the practical implementation. So we'll start with the first presentation. So I'll hand over to Dagi.
Yes, thank you, Andrea. I'm going to share my screen. You can all see my presentation screen right now?
No, not yet.
Not yet.
I'm trying again. Normally you can. So right now you're seeing my screen.
Yeah,
oh, that's fine. Yeah. Thank you, Andrea, for the introduction, and good afternoon, everyone. So I'm Dagi Boykens, and I'm an occupational therapist, also a health promoter, and currently doing a PhD on the topic of goal-oriented care, in which we're trying to develop an intervention to implement goal-oriented care in the primary care context of Flanders. And in the next 20 minutes, I will present you the concept of goal-oriented care to provide you some more background information on the concept and a general introduction. But first, I want to situate the research on goal-oriented care in Flanders. And I think already 2 years ago, or a little bit longer, the Primary Care Academy has been established, which is a consortium of different universities, University of Applied Sciences, also organizations of patient representatives, that has an overall aim to implement a person-centered care approach in Flanders by the means of research and education. And one of their topics is goal-oriented care. I also want to pay attention on the Summer Academy that we have organized in September 2019 in collaboration with Daniel Koning Fund and the International Neuling Collaborative on Goal-Oriented Care. And this Summer Academy has published a report to present or to wrap up the most important messages and the presentations that has been given at this Summer Academy. And it's not specifically scientific information or knowledge, but also a general introduction on the concepts. And that leads us to our main question, or the main topic of today: if patients' goals or goal-oriented goal-oriented care could be a key to integrated care. And hopefully after Hennis and my presentation, you gain some more insight in a possible link to both concepts. And that finally leads me to the concept of goal-oriented care. And it's first been published by Malt, or Malt was one of the first researchers to publish something about goal-oriented care in 1991. And he was one of the first to state that the problem-oriented model, or the medical model to which the current healthcare system is mainly oriented, is not well suited for chronic conditions. And he proposed goal-oriented care as an alternative paradigm or an alternative way of approaching care. And however, there is currently no common definition or no common understanding or of the topic. Malt specifically sees it as the maximum desired quality of quantity of life defined by the individuals, and the individual is seen as one of the key figures when it comes to delivering care. So therefore, we have to translate the question, what's the matter with the patient, to what matters to the patient. And we think that goal-oriented care could be a well-suited strategy to achieve the question, what matters to the patients. And however, goal-oriented care could be seen as a simple concept to understand. There still is a huge lack of underpinning knowledge on which characteristics goal-oriented care is built and how goal-oriented care should be put into practice, and also related concepts such as patient-centered care, person-centered care, shared decision-making, and so on, challenge the understanding on the concept. So for making it more understandable, so providers and also policymakers, of course, could better use goal-oriented care in their practice or in their policy, we have conducted a concept analysis based on the method of Volcker and Novant to gain some more clarification on the concepts. So the results I'm going to present are still unpublished. We are hoping to provide a forward to the article as soon as possible, but it's on the way. So to gain some more clarification on the concept, as I already said, we conducted a concept analysis, and concept analysis, the three main steps or three main most important phases of conducting concept analysis are defining attributes, antecedents, and consequences. And I will mainly focus on the attributes of goal-oriented care because they represent the overall characteristics of the main, provide the most insight in their understanding of the concept. And for goal-oriented care, we specifically found that it's a dynamic and iterative process consisting of three phases: goal elicitation, goal setting, and goal evaluation. And it's an ongoing process, and rather than a one-time intervention. So goal-oriented care is a process which means that it's, you have to provide it in care over time rather than the one-time intervention. And we know that in current research that in realistic settings, this could seem like a too delineated process, and the different stages could not be identified. But the main message I want to give you today is that goal-oriented care is like more philosophy of care that has to be taken into account when providing care to patients or when organizing a new healthcare approach, instead of checking if all phases could be identified. And in addition to stress the philosophy of care, there are also two more underpinning attributes in the patient's context and the patient's needs and preferences that have to form a common thread throughout the entire process, and they have to be represented in every stage of the goal-oriented care process. And before I will come to some more information about the attributes themselves, I would like to present to you Joseph. And Joseph is a 6-year-old man, retired, and he loves spending time in his garden, playing with his grandchildren, and cycling. Was a passionate cyclist, but is challenged by multiple chronic conditions as diabetes, hypertension, and cardiovascular disease. And in his monthly checkup with his family doctor, he discussed his wish to cycle again. And if we link that to the first stage of the goal-oriented care process, which is goal elicitation, we see that Joseph has a chance to share his story in more likely open communication with his healthcare provider, with his family doctor, and he experienced trust and mutual respect. And that's what it is about in goal elicitation. So providers are presumed to offer time and space in the stage of goal elicitation, so that the patients can tell their story and are open to share their concerns, and which makes it possible to work towards the patient agenda. This stage is also considered to be essential to work towards a more balanced patient-provider relationship based on that open communication, trust, and mutual respect. So goal elicitation has to set, you can say, has to set the stage or the context to create supportive context for the goal setting stage, which I already mentioned as a second stage of the goal-oriented care process. And although it could seem easy to elicit the patient agenda and just to listen to the needs and preferences of the patients, it doesn't present that in research. So Ospina and colleagues, for example, concluded that providers seldom elicit the patient's agenda, and especially providers from specialist care elicit in lesser extent the agenda than providers from primary care. And that reduces also the chance that providers will orient their consultation towards specific aspects that matter most to the patients, which is the most important message or most important foundation of goal-oriented care. And after, if we make again the link for the second stage of goal setting to the case of Joseph, Joseph had the possibility to share his story and his wish in an open communication. His doctor doubts his wish to cycle again, and Joseph and the doctor have a small discussion and share their own goals and main concerns. And they conclude that Joseph could go cycling again and agree that the doctor will make some adjustments to the medication scheme in correspondence to the increased efforts Joseph will make. And that's what goal setting is about again. A goal setting should support the patients to continue doing what matters most to them. So have to reflect the patient's needs and preferences. And it's mainly characterized by patient-provider interaction based on collaboration, negotiation, and balance. And a collaborative interaction means that both the provider and the patient has to share their needs and preferences or their main goals they want to work towards during their consultations, and have to work towards a common goal. And in negotiation, we mean that all partners has to discuss the problems they're facing, explore the patient's values and have some discussion about it in face of the needs and capabilities of the patients themselves, which enhance, in that perspective, a more balanced relationship. And elaborating on the goals, you could say that the goals should be grounded in the patient's needs and preferences and represent what the patients want and not necessarily what the providers want, which can cause some moral distress for the providers in what doing good for the patients and doing good for the health, as described, mostly described by the medical guidelines. And despite an overall consensus of that the goals should be based on the needs and preferences of patients, it's not clear how and which goals are set. So some examples of research that has been conducted to provide you an overview of model of personal goals. So has Vermoont and colleagues developed or presented a three-level goal model containing disease or specific goals, functional goals, and fundamental goals, which allows patients and providers to work in a more collaborative goal setting. And not only is there a knowledge gap on which goals are set by patients, it's also not clear how goals are being set. So there is a need to develop some strategies, as Manga said, to make patients' goals more visible, also in the clinical record and the medical decision-making. And making them more visible in the clinical record is something that Henny also will discuss in her presentation. And going further on the third stage of the goal-oriented care process, goal evaluation was identified. And again, relating to the case of Joseph, he and his doctor agreed to have some reflection, feedback on his wish to cycle again, and they agreed to evaluate it after 3 months. And that allows the doctor and Joseph to make some adjustments to the medication scheme or adjustment to the care plan based on the increased or decreased intensity of Joseph and how he's feeling. And goal evaluations not necessarily mean that a goal should be attained and a goal should be measured, but it's more the reflection and feedback that's the most important part in the stage of goal evaluation. And this stage allows also the redefining and adjustment to goals, which also characterize the iterative and dynamic process that goal-oriented care is. And possible reasons to adjust goals might be that a goal has to be too difficult to achieve or are no longer desired or relevant to a patient situation, because the care situation of a patient and I think its wishes could change over time. So it's a fitted moment to reflect on the process. But we see goal evaluation also as a threat for a goal-oriented care process, because patients' goals would be simplified to what can be measured. Instead of a life goal of a patient, a life personal goal is something that's very difficult to evaluate. If you think, for example, to a goal, I want to take my grandchildren from school as long as possible, is a very difficult goal to measure. So there are still some knowledge gaps on that. And working towards goal evaluation might also increase the pressure on patients and providers to work in the same way as guidelines do. So we would simplify the goal-oriented care process to working towards guidelines again, and may lead to the same pitfalls it has. And as I already said in the beginning of my presentation, the whole goal-oriented care process should also be underpinned by some patient's values. In the case, again, for Joseph, we see that he was a passionate cyclist, and also his friends and wife support his initiative because he would get fitter. He would also have more social context, and his friends and wife find it very important. And that's what the patient's values should be mirrored. And the whole goal-oriented care process, so from the goal elicitation phase to the goal evaluation phase, needs to be placed in the patient's context, which not only means that it has to be reflected to the personal context, but also to the social and cultural context tailored to the patient's situations. And in addition, patient needs and preferences, as I already said for a couple of times, should form a common thread during the process, reflecting the question, what matters most to the patient. And not only we identified some attributes and the main characteristics of goal-oriented care, we also found some antecedents. And antecedents, you can consider them as some preconditions before applying goal-oriented care, and events that has to precede the application of goal-oriented care. And for goal-oriented care, we've specifically found that both the provider has to be prepared and also the patient has to be prepared. In terms of provider preparedness, we see that training is a very important component. Training is not only, there is no specific framework to which training has to be set up, but we see that an interprofessional training is very important so that different disciplines can learn from each other. And also, that's a point that Henny will further discuss in her presentation. And providers also need to have some personal skills as communication skills, the ability to listen to their patient, to their person, and be some witnesses of the story of the patient and the life of the patient. And in terms of patient preparedness, we see that there is big attention given to education, guidance, and skills to set goals, because patients are not used to reflect on their own needs and preferences and are used to enter a care relationship and share their health problems instead of their, for example, life goals. So there are two main preconditions when applying goal-oriented care. And if I go on with the consequences, there are not only antecedents that have to be fulfilled. For goal-oriented care, there are also some consequences and results, you can say, after applying goal-oriented care on the level of the patients, providers, and the care system. If we go on for the patients, consequences, we see that we expect more patient satisfaction, because the values, preferences, knowledge, and opinions are more heard, leading to the feeling of being heard and understood from the patient side. And these feelings will lead to an increased commitment and adherence in the care process and increased satisfaction. If we see for the provider preparedness, we see that goal-oriented care could help them in decision-making and gave them the opportunity to get to know the patients better. It enhanced the collaboration between the patients and the provider, but also under the providers themselves, and could facilitate a more interprofessional collaboration, because they're working towards the goals of the needs and preferences of patients instead of working towards their own health-related guidelines. And this enhances, because they see that their patients are more satisfied, this also leads to more job satisfaction for themselves, which improves the overall care setting, the quality of care they offer. And if I go on for the consequences of the care system, we see that there is a main focus on reducing costs, over-treatment and fragmentation, again, because care is organized based on what the patients want and what their wishes and preferences are. So in some cases, it could lead to reducing costs, tests, and treatments. But I want to mention also a downside of goal-oriented care, because I just presented some major benefits on the 3 levels, but there are also some considerations that have to be taken into account. And some decisions, as we've seen, to strive for personal goals may worsen a provider performance, and, as I already said in the beginning, cause some moral distress by professional by doing good for the patient and doing good for the health. And an example of that is a diabetic patient that has chosen to not follow his diet and to keep on smoking, because otherwise he has to undergo a too big lifestyle change. His HbA1c level would not be aligned with the clinical guidelines that doctors have to follow. And it could seem like a positive outcome from the patient perspective. It would influence the quality of care as it now is recorded, and the population health in a negative way. So it's very important to not only focus on the way how quality of care is not measured, but to find a way in between. And I'm already at my last slide of my presentation, and I would conclude to show with showing you the overview of what I just said, and again repeating that goal-oriented care could be considered as a dynamic and iterative process consisting of goal elicitation, goal setting, and goal evaluation. And in order to be able to deliver care according to these principles, both the provider and the patient should be prepared, so based on training, guidance, and support, and developing some skills. And in terms of consequences, we see that goal-oriented care has the potential to improve patient experiences, provider satisfaction, has the ability to reduce costs, and overall, we can conclude that goal-oriented care, however, it has to be further explored and further research has has to be done, we can consider that goal-oriented care has a potential to improve the population well-being. So that was all I wanted to say about the concept of goal-oriented care. It was a short presentation introduction on the main aspects of it. If you still have questions, of course, we have a discussion that's following. You can always send me an email. Some main references I refer to in the presentation and some interesting literature to read and to learn more about goal-oriented care. So I want to thank you for your attention and yeah. And looking forward to if there are any questions.
Thank you. Thank you very much. I think we're just going to go straight on to Reina for the next speaker. Is that okay, Andrea? Do you want to pause?
No, that's fine. We didn't have a dedicated time to go through the questions. So yeah, we can go to the second one.
Okay, so Reina, if you can share your screen with us, thank you.
Yes, okay. So thank you, Dahi, for your presentation. Thank you, Nessa, for the introduction. So I'll first introduce myself a little bit with camera so you know who's talking to you, so you know like the face behind the voice of these following minutes. So my name is Reini Havrals, and just like Dahi, I'm also an occupational therapist from background. And now since the beginning of July, I started working as a colleague of Dahi at the University of Ghent, also in the research group of goal-oriented care. And now, so during my presentation, I would like to introduce you to how we are implementing the concept of goal-oriented care in the care system in Flanders. But so now I'll stop my video so you can fully focus on my presentation. So this is now fully shared, right? Everyone can see
Yes.
the presentation?
Yeah,
Okay,
perfect.
perfect. Thank you. Okay, so as you could hear during the presentation of Dahi, we have been focusing on clarifying this concept on goal-oriented care in order to properly understand it. Now, following to this presentation, I was so asked to give a short introduction to the implementation of goal-oriented care in Flanders. And because once a concept is clarified, then the question arises of how can we implement this concept in our healthcare system. And so that's something that in my work as a researcher, I'm mainly concerned with. And so therefore, during my presentation, I'd like to present to you two projects that show how we strive towards integration of goal-oriented care in the Flemish care system. And to show you the level and the type, there we go. And to show you the level and the type of the integration for both projects, I'm using here the model of Valentine as a visual. Because important is that in both projects, we are paying attention to both functional integration and normative integration. Because from a normative perspective, we want the vision of goal-oriented care to be embedded in the organization of primary care. And on the level of functional integration in both projects, we also take a look at how we can offer concrete tools to patients, caregivers, and healthcare providers to use goal-oriented care in their daily practice. So now the first project that we will have a look at, it's a project on the level of the system. So it's a project initiated by government on the implementation of goal-oriented care as a vision in the digital healthcare record. And then the second project that I'll talk about will be on the level of professionals and services. And here we will take a look on how to build goal-oriented care out as a common vision or as a common vision of work in primary care that can provide concrete tools for guidance. Now, as I said, so the first project, that's an initiative from the Flemish Agency of Care and Health, because in 2019, the Minister of Health here in Belgium, he declared that care should no longer be based on what we can offer, like as from care providers, but that we should, that care always should contribute to the quality of life of the patient and thus that we should always start from what the patient's needs are. Now, to facilitate healthcare based on the needs of a patient, government decided to develop a digital healthcare plan where life goals of a patient form the baseline of care planning. So they want goal-oriented care as a fundamental vision in the design of this new digital healthcare record. And so the question arose like, how can we use goal-oriented care as our foundation in this care plan? And so that's one question that we will be investigating with our team for the next 6 months. Then the second project we're working on, that's the development of a training in goal-oriented care. And this question came from the Flemish Institute for Primary Care. And this institute that defines policy and organization of primary care in Flanders, they are convinced that goal-oriented care could provide a better collaboration and quality in primary care. And therefore, they asked us to develop a training package so patients, informal caregivers, and healthcare providers can work according to the principles of goal-oriented care. Now, before I continue my presentation, I would like to make one important remark, and that's that when I'm talking about care, I always mean healthcare and social care. So it's not that we only focus on the medical healthcare, but we think that especially in primary care, it's really important to take a look at healthcare from all different forms. So now I'll get a little bit more detailed to this first project about goal-oriented care into the digital healthcare record. Through this research project, we want to develop a healthcare record in which the life goals of a patient become central and from which the care team can efficiently extract operational care goals. And to develop this, we are solving two research questions. So the first thing we ask ourselves is, what structure is needed to support the patient and care providers in reflecting life goals in the healthcare plan? So basically, we look at how can we give some guidance to patients and care providers on how to formulate such a life goal of the patient into the healthcare record. And then second, when the life goal is set, we want to know how a care team determines the operational care goals that are linked to this life goal. So here we question like, how can individual professionals and care teams translate this patient life goal into operational care goals? So here we take a deeper look into what steps are part of the process of how we go from a life goal to a care goal in a structured way. Now, the method that we will use for researching both questions always exists of 4 stages here. So first, we will take a deeper look into what existing literature there already is on frameworks and definitions on life goals and how this literature describes the relationships between them. And then secondly, we will perform a document analysis on the existing tools of goal-oriented care. Because in Flanders, there are already actually existing several practical tools that help care providers in practicing goal-oriented care. And so for this document analysis, we will take a deeper look into these documents concerning these tools, and we hope that they will learn us better how the construction of a life goal is consistent and how this could give some structure to form them in the healthcare record. And then in addition, we will also do some field research because now in February, some care providers will be trained by us in goal-oriented care. And during this training, we will ask them to apply goal-oriented care in their practice. And specifically, we will ask them to have conversations with patients where they discover and formulate this patient's life goal. And then we also ask them to discuss this life goal with their team and to create a care plan based on that life goal. And so all these conversations between the patients and the professionals and these teams, they will be videotaped and we will be analyzing them. And so this will give us also insight into that process from life goals to care goals. And then finally, we will also conduct some interviews with our participants, with professionals and patients to gain more insight into their experience with goal-oriented care. And so all the results from these 4 stages, they will be the input to research our 2 research questions. Then the results of this project will be mainly consisting of 3 outcomes. So first of all, there will be a report on all our findings and recommendations. Then second, we will provide a workflow on life goals in the healthcare record. And so this workflow should allow care providers on how to use life goals to form a care plan around this. And finally, we will also in June, in upcoming June, we will present our results for the Flemish agency. So this was in a nutshell the plans that we have for this project, which we just started on right now in January and which will finish in June. Then we arrive to the second project about the implementation of goal-oriented care. And here it's the Flemish Institute for Primary Care that asked us to look at how we can use this vision of goal-oriented care in primary care. And the Dutch abbreviation for this institute, it's VIVEL, as you can see here in the right corner. And this project has already started some time ago. They started at the beginning of 2020. And so it has already gone through quite some steps that I will show you right now. So, so the question from Vivel arose because for some years now, goal-oriented care has been gaining importance in Flanders. And various experts and organizations have been developing tools and trainings and methodologies to provide goal-oriented care. And so this has led to the creation of different tools on goal-oriented care in different regions in Flanders. And so in the first phase of this project, we had to identify what different tools on goal-oriented care already existed. So that's what you can see here on this map. And then in the second phase, we brought together all these different developers of these tools. And we had them make a look at what common building blocks there are in these tools on goal-oriented care and how these building blocks can form a training out of it. Because the main goal in this project is to bring together all these expertise and make an overall training on goal-oriented care in which all these tools can recognize themselves. And so to find these common building blocks, we organized different co-creation days where the concept of goal-oriented care was discussed and how it should be trained to patients and professionals. And so here you get a small glimpse of how such a co-creation day would look like. And as you can see, it consisted of many, many whiteboards and post-its. And so finally, we developed this training package on goal-oriented care. And the main goal of this training package, as you can read right here, is that the participants, by the end of the training, they, first of all, of course, they should know what goal-oriented care is, what conditions there are for practicing goal-oriented care, and then also what the advantages could be for all persons involved in the care situation. And while developing this training, we divided it into 2 different versions. So first of all, there will be a training on goal-oriented care where we like to invite just a broad audience to get to know the idea behind goal-oriented care. And then after this general training, we will also offer a specific training for healthcare providers in primary care. And so practically, the general training, it will consist of 4 online webinars in which the concept of goal-oriented care is explained and why it can be important and how to use it. So these webinars, they have the goal just to inform and enthuse a wide group of people who are curious about the concept. And so these webinars, they have the characteristic that they are made from a citizen's perspective. So they will be very accessible and understandable and open to everyone, to citizens, to patients, their informal caregivers, professionals, and so on. Then the specific training, that's a more profound training for healthcare providers working in primary care. So after the general training with the webinars, care providers can participate in the specific training with 4 training moments. And important about this specific training is that all training moments will always be organized in a group of professionals that work together in the same network. Because as you should know, primary care in Flanders, it's organized and divided in 60 different primary care zones. And the idea of these zones is to facilitate collaboration within a specific region. And so also with our specific training, besides learning on this concept of goal-oriented care, we also strive to facilitate this interdisciplinary collaboration between care providers within their network. Because from the view of goal-oriented care, we also believe that it is something that you cannot just do by yourself. Goal-oriented care is something that you do within a network with your colleagues, with the patients, with the caregivers, and so on. And so at this moment, we are in the phase of doing the pilot of our training. And so in February, we will train the first group of care providers here in Ghent to learn from their experience. And then later, we are planning to upscale this training to all primary care zones in Flanders. So here, I end my presentation on the implementation of goal-oriented care in Flanders. And now the only thing that rests me is to open the conversation on how goal-oriented care might be linked to integrated care, and more specifically to the 12 dimensions of the maturity model. Now, I must say that I'm actually totally new to this model, so this is all based on my first experience with it. But from this first experience, I have the idea that we can see a link between goal-oriented care and almost any dimension of this model. Because I believe from what I've read about these dimensions, is that there are many common goals between the vision of goal-oriented care and integrated care. Now, to specify these common goals, I will just like to highlight here a few dimensions I thought that were really interesting, also concerning the projects I just discussed. So first of all, this dimension on structure and governance, it's one that has developed a lot the past months on the topic of goal-oriented care. Because we experience that goal-oriented care is gaining attention, not only by professionals and services, but also from government. And so we get more questions about the concept and how to use it in practice. And it's thanks to this increased attention that we are able to work on the projects like this training and this digital healthcare record and so on. And when we talk about government and implementation of goal-oriented care, an important part of this will always be how can goal-oriented care be a financially interesting topic? And research, as also Dahlia already has said, is that research has shown that for certain groups of patients, goal-oriented care has the potential to deliver efficient care that even can result in fewer costs in healthcare. But now, one big question that remains, it's the way of how to evaluate the results of goal-oriented care. And as the implementation of goal-oriented care is getting more attention, so also this part of the evaluation will for sure need some more attention in the future. Then two other dimensions of this model are removal of inhibitors and citizen empowerment. And concerning these topics, we believe that to let people make use of goal-oriented care in their practice, for some professionals, this means actually a huge change in their work culture. because as healthcare professionals, many times we're trained to help the patient, to do what's in our power to solve their problems, and to put it maybe a bit extreme, it's like to rescue the patient. But now, with goal-oriented care, creating empowerment in the patient and initiating a shift in power from the professional to the patient, it's something that needs a big shift in perspective as well, we think. And then finally, this capacity building, it's also something we intend to do with our training on goal-oriented care. And therefore, we are using now two strategies. So in the first place, we use the diffusion of innovation theory by Rogers. And this theory states that change comes when a small group of innovators have a strong belief that implementing a particular strategy, so goal-oriented care in this case, that strategy will improve patient care. And this belief is then passed to early adopters who take this idea into the field. And so within the development of our training, the developers of these existing tools, they were our innovators. And the people that will get trained now in February, they will be our early adopters because they are the care providers who are already a bit convinced of the idea behind goal-oriented care. And they will bring this idea into their network of professionals. And so this idea of goal-oriented care can expand. And in this way, these early adopters in the future could become practice facilitators once we roll out this training into the different care zones in Flanders. So these were just some examples of how we see different links with the application of the maturity model in our projects on goal-oriented care. But for sure, we think there are many, many other links possible to make. So thank you for listening to this presentation. And of course, if you have any questions about my presentation, you are more than welcome to ask them. And so therefore, I think now we will have a small conversation about this link between goal-oriented care and the maturity model, as I'm not mistaken, right?
Thank you. Thank you very much. It's a really fascinating, two fascinating presentations and lots of thought-provoking information and some really good questions also in the chat. Andrea, do you want me to just go straight to the questions we have while these are fresh with people, or do you want to come in and speak more about the maturity model?
No, I think that we can definitely kick off with the questions and then continue with the discussion on this link between the concept of goal-oriented care and the maturity model.
Okay, so I'm just going to pick these questions up in the order, hopefully, that they have come in the chat. So if I miss your question, feel free to nudge me and remind me about it in case I do. Andrea Pavlikova had kicked off with asking a question about what different ways, and this is picked up in 2 or 3 of the questions, what are the different ways of measuring the consequences or results of applying the concept of goal-oriented care? Now, some of these you've touched on in your presentations, but I just wondered if you wanted to refer to that. So Andrea has mentioned patient satisfaction, job satisfaction. You have referred to some of these. But we also had a question which related to costs and the impact of this way of working. Are there analyses which show consequences around cost reduction, for example? And we had a question from Jane about whether any cost benefit analysis had been undertaken. So I'm going to group those together if that's okay. And if I ask Reina, if you want to start.
Mm-hmm. Yeah, so exactly the first thing about the evaluation, as I actually just mentioned here with this maturity model, that's something that's still a very big question mark, as I said, on how to evaluate these things, because there are many aspects when we want to evaluate goal-oriented care, I think, because in the first place, we want to evaluate the happiness or the satisfaction on the patient. Like, does he find his life goal being being recognized in the care planning that is organized around it. And then on the other hand, we also have our care providers who, for sometimes they are sometimes they really need to follow very specific orders and guidelines. And if they want to like step aside of that a little bit more and go a little bit more to the direction of that patient's life goal, then sometimes that means that he has to stop following these guidelines. And then the question arises like, am I as a care provider still doing my job good? Am I still delivering quality of care? So the question of what is how can we measure quality of care within this concept of goal-oriented care? That's still something that needs to be digged out more. And maybe these maturity model or this Sirocco tool might bring some answers to that. If we get a better insight into what it means, and I think it might bring some potential maybe. And then there was also this question about the finance, right? If it can be maybe interesting for lowering costs. And so there, I know that there is literature suggesting that for a certain group of people, and then mostly it has been proven within persons with chronic diseases and persons with suffering from multimorbidity, there we see that these patients, many times they are surrounded by many care providers, or they're linked to hospitals and general practitioners and so on. And that many times, if there could be more, like if all these care providers could work more towards a common goal, as we would state here then as the patient's life goal, this might make things more clear of what is necessary care and what is unnecessary care in this case. And so therefore, it might give some possibilities as well in making the costs more efficient in care. But I don't know, maybe Dahlia, if you could, I don't know if you know something more about that on the financially interesting part of goal-oriented care, because you also mentioned it a bit in your presentation, right?
Yes, so if we make, indeed presented some consequences of applying goal-oriented care, which also included cost reduction and benefits for the care system. And currently there is not so much known about very cost-related analysis that has been done on applying goal-oriented care or in broader insights patient-centered care. But some randomized control trials have tried to gain more insight in potential benefits, and they mainly focus on the outcomes of quality of life, indeed patients' empowerment of patients' engagement in care, and some may offer, or for example, lesser self-management tasks and so on. I will, if you're interested, I can forward you some interesting links to those researchers. And they found that there is, in lesser extent, which was related to lesser costs of goal-oriented care, there are less referrals, less diagnostical tests, etc., in compared to persons who received the normal way of care that's provided. So there still has to be done much research on the cost effectiveness, but the first results show that due to lesser referrals, lesser prescribing of diagnostical tests, patients are also more satisfied, and the care system is spending less money.
That's really interesting. So potentially an impact for the service provision, but obviously not ignoring the wider impacts and the impact for the individual and the patient and the staff who provide this type of service. I also thought that was a really interesting idea, that if care providers could unite around a goal or a series of goals that were defined more with the patient or with the citizen. And perhaps that would help to make complicated care for people who have multiple conditions a little bit more joined up in terms of its approach. I don't know why I'm smiling, because that seems almost impossible to achieve at times when you talk to people who have got multiple long-term conditions and dealing with the system that they deal with to deal with all of those things. Okay, I will go back to the questions and stop chatting. We had a question actually from Lamas, I think it was, and it was more about the process. I think the question was about process evaluation, so you can correct me if I'm wrong. So it was interested really in the methodology. So are there ways of, let me see, yeah, are there recommendations available or information available about indicators that would measure the goal-oriented care process? So I think that goes to the process evaluation of the method. So if you have anything on like that, if you can add it to the chat, or if you want to say anything about that, I will just let you come in.
Yes, that's related to, I think, our last answers or the previous question, is that we are working on that to find some process indicators to measure goal-oriented care or to evaluate it, because I think that's the key to convince policymakers or policy to implement goal-oriented care, because you need something to prove or something to measure if it works or not. So we know that we have to focus on the process of goal-oriented care, or the process of care giving following such an approach, instead of outcome measurements, because we're facing the same pitfalls as the medical guidelines do. But we don't have a framework or a checklist of indicators to measure goal-oriented care. But we know, of course, that we have to find indicators or find a way to measure the life goals of our personal goals, which also includes the patient engagement, the way how the interaction went between the patient and the provider, and so on. But it's very difficult to describe them, to complete or to address the goals of those patients in terms of indicators. So that's a big question mark where we are working on. But I think it's one of the main things to convince others to apply goal-oriented care.
Okay, I'm just going to jump back to the questions, because I want to give the opportunity for people to have the chance to ask. I had shared a link to a resource that has been a resource and a campaign that has been going on in Scotland for a few years now, called What Matters to You, or if it's What Matters to Me as a patient. And it's in the chat if anyone wants to look at it. It is not exactly the same, but there are some similarities which you will see if you look at it. It's about defining what's important to service users and patients and staff in the way they use and receive care. So just to say, if you want to share other resources, please do. Jane had noted that this approach, the What Matters to Me approach, had been used in Glasgow in the Hospital for Sick Children. So we have several questions from Diane. Diane, I'm not going to cover all of them, but I'm definitely going to have a good go. So the first question, really, I think you've answered this in your presentations, but it was about whether goal-oriented care is better done by doctors or by, for example, nursing stroke support staff, and how do medical staff find time to explore the goals with the patient if an appointment, for example, lasts just 7 to 12 minutes. And patient goals are much wider than that. You did speak about a kind of multi-professional approach, but I'll let you come in there.
Yeah, so there we experience that. I mean, about the question, I think it's a very interesting question. Like, what care providers are best at performing in goal-oriented care, and there we see that like the professionals of like the social workers and the occupational therapists, that when we explain the concept of goal-oriented care to them, that they are actually very familiar with this concept, and they have the feeling that they say like, yeah, okay, but that's what we do, you know, that's how we're used to do it. We always try to work this very patient-centered, in this very patient-centered way. And then of course, indeed, there are other other types or disciplines of care providers who have more difficulties with getting, or where the culture in, or the shift in perspective is much bigger to go to goal-oriented care. And also because of, as you might mention, the time. That's a very important thing, especially for the phase of the goal elicitation, which is really, it's like the first encounter you have with your patient, where you discuss truly like his life story and what's important to you, what are your values, what are things that I need to know when I'm care planning all these things for you. And so time is always a very big like a burden, or a difficulty when we try to implement goal-oriented care into our system. And therefore we, for the moment, so as we are trying to implement this concept of goal-oriented care also into the healthcare records, we really want to state that all these different stages in goal-oriented care, the goal elicitation, the goal setting, and the goal evaluation, they're all as important. Because most of the times we start with the goal setting, and we first say like, okay, so what's important here, this and this. But the whole starting point from to define these goals, this goal elicitation, that's also really important. And therefore the financial systems should recognize this stage, like the stage of the goal elicitation. So yeah, indeed, like at the moment it's really difficult for care providers to have time, or to be able to make time for this goal elicitation, and to sit with their patient at a table and to say like, okay, let's discuss what's important in your life, and then I will see how I can do something to you, so that you are able to do the things that matter in your life. So that's true. And that's something I think, while we're now doing our first pilot in February with the training, and we'll see how these care providers experience it, and how realistic they think at the moment it is to be using in their practice. Yeah.
Okay.
But I just want to add something that we see, that's also, however, it's time consuming during the first encounters. We see in results that on longer term, applying goal-oriented care reduces time of consultations, and it will enhance just the care delivering process. So it's
Yes.
balance between the first and the last.
Yes, so it's an investment in the beginning, but you gain from it at the end. That's also how literature describes it.
Okay, thank you. That's really interesting. And that comes back to the point I think you made earlier, that in a way, the protocols that are in place often fight against the staff doing something in a more goal-oriented care way, because they have to get through a certain protocol or a certain series of steps in a care episode. So it can be very difficult to carve out that time, or to work against that protocol or checklist. And Diane gives an example about goals being based on many stages, support from family and friends, being able to get the bike out, going for a cycle, being able to do certain types of exercise. So it's quite hard to Diana's making the point about that wider context in which we as citizens live. I think, Diane, I'm not trying to put words in your mouth. And it's quite hard to elicit goals and understand what goals are in all of that, I imagine.
Yeah, exactly. Yeah, so this context that we're talking about, it's really important, and it's also because I was searching for the question of Diane, and I see that it ends like with the question: does the system in Flanders help patients to understand this far wider context? And then, do you mean, Diane, something with that? Like, are our citizens in Belgium prepared to also participate in this goal-oriented care, or do they know how to, for example, set up their patient goals? Is this how I should interpret your
it's
question?
Diane here, and I apologize in advance because I've stayed on for 6 minutes more, but I do have to leave. My point rather more was to what extent do people apply goal orientations in their own lives, and do they have the habit and the approach of doing this, i.e. you're using health in a way as the input, as the leverage to get people to think about their lives and their life goals. And I think my concern was a little bit like that of Johanna, which is a question that'll come up in a couple of minutes' time. But it was really, one can alter what one can alter in a personal or in an individual life, but there are some societal contexts that maybe it needs a group and a community and a whole society or nation to change. So I was interested in how much your health and your care providers are then working within a, let's say, a multi-stakeholder platform and within a whole ecosystem. Thank you.
Yes, thank you for your question, Diane. So indeed, it asks a really big change in perspective from healthcare provider. Although it's a bit mixed, because we have the belief that it's always the main goal of a healthcare provider to do good for the patient. But so now here the question raises, like, how are they able to maintain this or to succeed in this? And it's in the first place the patient preparedness, I think, where you're talking about, like, is the patient prepared to participate in this goal-oriented care? And therefore, I think certainly for a lot of patients, there will be needed some of this patient preparedness, and we will have to educate is maybe not a good word, but to show patients on what role they can take into their relationship with their healthcare providers, and that they can take some responsibility in their if they want to, and how they can do this, and how the care providers can empower these patients to do so. And then on the other hand, the other question that you asked is that if there is this ecosystem or this interdisciplinary network where they're working in. And that's also something that gained much attention in Flanders, and that's why these 60 care zones are created, because they're very, very new. They're just exist now for like 1 year in Belgium. And where the main goal really is to scale up these interprofessional collaboration. So we really want to go to care in Flanders, where it's a network of interprofessional care providers, formal and informal. So and also not only care, but also social health and mental health, and all these partners around it, and like voluntary organizations and these things, who can really form a very nice network and structure around the patient, where he can find himself in. So I don't know if that's a bit an answer to your question.
Yeah, no, I think that definitely does help to put it in the wider context. Again, I'm just going to come back to the questions in the chat. So we've had a couple of questions actually from different people, but they're very similar, I would say. And so Diane mentioned the question from Johanna, and this was about how can we avoid the definition of life goals actually increasing existing inequalities? So for example, Johanna goes on to say, how can we avoid people with less money, for example, less education, less networks, who are struggling with their health? How can we avoid them having less ambitious goals for their own health, but also avoid health and care professionals? So this is the structure. When they conduct the interviews, have a less enabling or empowering way, because the health and care professionals may have limiting beliefs for the citizens in certain situations. So there's a kind of inbuilt inequality. I think, Johanna, again, I don't want to put words in your mouth, but I think that's what you're alluding to there. And a similar question from Jane. I should say some people have shared resources in the chat. I'm not going to read them all out, but if you can take a look there about realistic medicine and that approach, you might find that interesting. So sorry, I'm scrolling down. Jane has also picked up on this point and asked about the practice of goal-oriented care. How can we make sure that it's sensitive to inequalities which exist, and that the approach does not itself just widen the gap? And will such areas be covered in the training? So that's maybe a way into that question, whoever wants to pick it up.
I will first give you some, So in the antecedents, we have indeed mentioned that patients have to be prepared to apply for goal-oriented care or receive goal-oriented care. And we also see that a part of health literacy, I think we're talking also a bit about health literacy and the level of health literacy of patients. And I think that that has to be mentioned in the patient preparedness. But although I think goal-oriented care is an approach that's suited for every kind of every population, also patients with lesser resources or lesser social context. And I think it's the task of a healthcare provider to provide care at the level of the patients and to enable patients to reflect on their goals. And every goal that is set is a good goal. We don't have, it's not a game on which goals has the highest value or something like that. So it's about encouraging patients in setting goals and thinking about the way they want to go in their life, in the care situation, and encouraging them to just think about it. And that's a big part that it has to addressed in the patients or in patient preparedness and antecedents. So we just have to be aware of those inequalities. And I think providers are well-suited persons to tailor their care to the patient's abilities.
Okay, and I just want to pick up a couple of comments, and then Andrea, I'm going to come back to you if we want to just maybe focus the last part of the conversation about Scirocco Exchange and the maturity assessment tool. So last few comments, if I've missed anybody, I apologize. You can shout at me in the chat if you need to. So Matea, hi Matea, she's mentioned that in Slovenia, she's found the presentations really inspiring, and in Slovenia, they're piloting personal care planning, a method based on David Brandon, which is very similar. They're also trying to evaluate the change then in the quality of life for the users, informal carers and providers. And it's also quite complex to evaluate. I absolutely believe it is quite complex to evaluate. Tino has just mentioned some excellent presentations. Thank you. And I think he's had to leave. And Saul has also saying thank you to our colleagues from Ghent. Excellent presentations. And mentioned that possibly talk about expansion around the maturity assessment model. And final question, sorry, I'm scrolling down, but my screen is not scrolling very fast. Let me just check. Stuart, Stuart Anderson, hi Stuart, and he has just asked, in goal setting, is there consideration of incentives for the stakeholders, which is an interesting point. I'm not sure if you covered that in your presentations. So incentives for the stakeholders, including the service users. Is that something that is used, and have you seen it used? And Dominique, I think Dominique may be correcting me, which is absolutely fine, or it's an additional point just saying that equity is the central issue in goal-oriented care, not equality. Okay, thank you, Dominique. So I'll just pick up on Stuart's question finally before we hand back to Andrea. I should say, incentives used for stakeholders?
I think it's a difficult question because I think incentives are mainly found for the stakeholders in the consequence and the satisfaction, and I think in the feeling they get after applying or conducting goal-oriented care, rather than, for example, financial incentives or so on. So there's also yes, there is also something that's not so clear and that's not taken into account in the organization of the care system. So we have also to consider if we have to provide some incentives for stakeholders so they get more motivated to conduct goal-oriented care. But I think for goal-oriented care, it's mainly about getting mind shift rather than really providing care in a different way. We think that every healthcare we think that healthcare providers also need to make the mind shift rather than applying a new way of care. And indeed, I'm reading this. I'm confused. I was reading the remark of Stuart again, and it's indeed wider than the financial incentives. But I think we don't think, because you're mentioning that was incentive to reach a goal. As I said in my presentation, it's not it's not necessary to attain a goal or to achieve a goal. It's rather a more a way of providing care and not working towards the goals, because we know that if you don't reach a goal, the patients are getting demotivated or to keep working on their care situation rather than keeping it as a process. So it's not, we don't need to have some incentives to attain a goal.
Yeah, and to just pick in on that a little bit more, just as Dacia said, it's not about to reach a goal, and what also Stuart writes in his comment is that thinking more wide than only these financial incentives, it's also something that, so in the first place, it's about the patient. It's about what's in it for me as a patient. What can care providers provide for me to what's important in my life, but also another very important incentive, both for the evaluation, the success rate of goal-oriented care, is what's in it for me, but then as a provider's perspective, because we also believe that goal-oriented care can bring a lot for like the wealth and the motivation and the satisfaction for care providers in healthcare, so that when they see that they can work directly towards in the direction of a patient's life goal, and they see that it increases satisfaction and health within the patient, and so they're actually doing very effective work, then this will also have very positive influences on the satisfaction of these healthcare providers. And besides, another interesting incentive might be that it could provide a better collaboration within your network, because goal-oriented care, it sort of forces you to gather everybody in your network together around the patient, and to think about how will we try to reach this goal of this patient. And so there will be set up a better interprofessional collaboration, and there also healthcare professionals might for sure benefit from that. So
Thank
that's
you.
a bit, yeah.
I'm just going to come back in and for leading off to Andrea, if there's anything you want to add. I know we're a little bit over time, but we've had some really good, I hope you feel we've had some good discussion and good questions. Regarding the model itself, the maturity model for Sirocco Exchange and any adaptation around that model, Tino had pointed out earlier in the chat that it would be very interesting, for example, to explore the connection between goal-oriented care and the population approach, and whether we could talk about collective goal-oriented care in the future, or whether community goals-oriented care. Those were just a couple of things that Tino was obviously thinking as the presentations were going ahead. Andrea, I'm sure you'll want to encourage people to kind of get in touch after the session, but if there was anything you wanted to raise just now, I'll hand to you.
Yeah, I just wanted to really just pick up briefly on that discussion on the potential adaptation of the model, because I mean, definitely listening to the presentation, to both the presentations, there are loads of commonalities, and I've liked actually the comments that Tino made. And just for the introduction, Tino Matti is really responsible for the work package, is looking at the adaptation and expansion. So I really like that point about the population approach. But also, I think that kind of like wider patient experience. I think you know, if you look through the dimension that we currently have in the MIT model, it's probably something that is not that you know, it's not that much reflective. We are looking at the citizen empowerment, but I think it's more from kind of like decision making perspective, policy making perspective. So I think that was really a good point from Rainy in her presentation. And I also like that point around investments versus finance, because I mean, if you probably look at the current definition of our dimension around the finance and funding, I'm not sure if we are actually capturing very well that investment part. So from my perspective, I think that this webinar was really a great start for the further discussion and for the further collaboration on how we can support our colleagues in Flanders to adapt this model to be really used in the primary care zones, as it was also mentioned by Sol in the chat. So there is a really good opportunity to keep working together and really, get something tangible out. So I mean, I would like to use this opportunity to actually start kind of like start this collaboration and invite our Scirocco exchange partners, but also maybe wider colleagues who would be interested to look on how we can adapt this model to fit better the needs in Flanders, and also maybe kind of like guide a bit maybe our Flemish colleagues on this journey. At least that's how I understood from Sol when we discussed this webinar. So I really think that this is a great start for the further for the further collaboration, how we can move this model forward to fit better the needs in Flanders. And I don't know if anyone else actually, maybe from the project partners, I know that maybe for external stakeholders it's difficult to comment, but maybe there are other partners who kind of like picked up on some observations, those who are familiar with the model and what we've heard from the concept that you may probably agree or disagree with from what I said, that there is definitely this potential, but I would like to take this as an opportunity to work on this initiative further.
Thank you, Andrea. I'm just going to offer if any of the partners wanted to come in, if you wanted to unmute yourself and come in, or if Andrea's covered it for now.
Just from my side, Nessa, if it's okay, it's Sol.
Thank you, Sol. Yeah, go ahead.
Well, thank you very much. Anyway, this is one of the, since long already, one of the best discussions that I've heard. So it is indeed, like I mentioned already in the chat, for us a rather important point, because we want to make the maturity matrix model really a sustainable tool in Flanders. But we see as well that we are committed also to implement the goal-oriented care, and we need to find a way that at the local level it will, we can use both, and we move together in that direction. So therefore, I think that for the other regions and other partners, probably they use already similar elements. So maybe they're also thinking about readapting the content of the maturity matrix and the questions in there more to their local level, and that might be interesting as well for us to know and to learn from them. And then maybe the last part is that from my side, I think the results of the training will be known in June 21, and I hope that it's okay there for Dacia and Reini and for you as well, that they can present it later on as well to the Scirocco partners.
Yep, I absolutely agree. I was going to ask them to come back as well. So that was perfect timing, Sol. Andrea, was there anything else you want to?
No, I just think I was just confirming what Sol said. That would be absolutely great, if you can follow up. And I think that we will obviously pick up that further work, logistics about the further work as part of our internal corner. We'll just definitely kick off with the proper collaboration on this, because it's been really interesting, and we would be absolutely very honored to support this further. So thank you so much.
Yes, we're super happy to be talking here and to get like connections with you guys and with this Scirocco project. So I think it will be great to keep you on track with the further findings of our projects, and to see how this implementation of goal-oriented care in Flanders works. Yeah.
Absolutely.
Okay, well, I will just say thank you then to our presenters, first of all, and for Sol for mediating, and Andrea for all the organizing, but most of all to the presenters who gave us a really good, clear description of the work underway and why it's important, which then allowed us to have a good chat about it. So thank you everybody for engaging on the chat as well. The session, as we said at the start, has been recorded, so that will be made available on the Scirocco Exchange website as soon as possible for anyone who couldn't join today. So I'm just going to say thank you and enjoy the rest of your afternoon, everybody, and we'll speak to some of you again soon. Bye-bye.
Bye-bye.
Thank you. Bye-bye.
Thank you.
Bye-bye.
Bye. Bye.
Thank you.